Good day, my name is Imelda Williams. With this presentation, I'm going to give you feedback on the forearm and wrist practice bank that I gave you. I trust that you have worked through the practice cases yourself and have completed the form. Keep your form at hand as I go through the feedback so that you can self-mark your responses. For case 1, we have a patient who was hit on the left forearm with a metal object. So if we look at the views that we have, it's not ideal. However, we can see that there is a significant fracture to the radius and that the fracture is displaced dorsally. We can also see that there is a dislocation of the radio-ulnar joint distally, and that is an indication of a Galeazzi fracture. So in our feedback then, the case is abnormal and the alignment, the bone, the joint and the soft tissue is abnormal. So there's a dorsally displaced radius midshaft fracture with associated dislocated distal radio-ulnar joint. You can also just write that it is a Galeazzi fracture. For case 2, we have a patient with a foot injury. So if we look at our DP view of the wrist, we can see when we look at the proximal row of the carpal bones that we've lost our normal configuration and the distance of the bones. And if we look at the lateral view, we can see that the lunate is slightly volarly displaced but still in contact with the radius. However, the capitate has been dislocated dorsally. Also on this view, there is a fracture of the scaphoid as well. So for our feedback, it's abnormal. The alignment, the bone and the joint is abnormal. So your overall comment is that there is a perilunate dislocation because the lunate is still in contact with the radius, and then there's a scaphoid fracture through the waist. For case 3, really important that you review this case very carefully. So on the DP view, we can see that there is a fracture of the distal radius, but importantly, it goes through the articular surface, which makes this a Barton's fracture. We can also see that there is a fracture of the styloid process. On the lateral view, you can see the fracture fragments going through the articular surface and that the pronator quadrata fat plane has been displaced anteriorly. So our feedback on case 3 then, it's abnormal and everything else in the specific opinion is abnormal. The overall comment is there's a comminuted intra-articular dorsally displaced fracture of the distal radius, which makes it a Barton's fracture. There's also an avulsion fracture of the styloid, and then you could mention that the pronator quadratus fat plane is displaced anteriorly. For case 4, again a foot injury. So if we look at our DP view, we can see that there is a fracture through the distal radius, but there are a number of lucent lines on this one, which makes it comminuted. And then there's also an styloid fracture as well. We can see that this is not a green stick fracture because the cortex is disrupted on both sides. And then on the lateral view, we can see that the fracture is displaced dorsally. So on our opinion form then, it's abnormal, the alignment and the bone is abnormal. And then the overall comment is there's a comminuted transverse fracture through the left distal radius with mild dorsal angulation. And there's a displacement of the distal fracture fragment as well. And in addition, there's an ulnar styloid fracture. So for case 5, we have a patient who fell down the stairs and the wrist is very swollen. That is the right wrist. We can see overall that this bone looks a bit osteopenic, so we're probably looking at an older patient. So if we look at the DP view, we can see that there's comminuted fractures. However, these fractures do not go across the articular surface. And on the lateral view, the fracture fragments have been displaced dorsally, and this is in keeping with the Colles fracture. And then again, there's also a fracture of the ulnar styloid. There is significant soft tissue swelling on this one. So for case 5, so everything is abnormal. So there's a comminuted extra-articular fracture of the distal radius with mild dorsal displacement, which is in keeping with the Colles fracture. There's also an avulsion of the ulnar styloid, and there's some soft tissue swelling of it. So case 6 was part of a wrist that was x-rayed, and then additional views were taken of the thumb. So the clinical indications were that there is an injury to the base of the thumb. And if we look at this case, we can see that at the base there is a intra-articular fracture. It's a two-part fracture, which makes it a Bennett's fracture, and there is no dislocation. So for the PIE form, it's abnormal, the bone is abnormal, the joint is abnormal because it forms part of the wrist joint, and then there's some soft tissue swelling. So the overall comment is there's an intra-articular fracture at the base of the first metacarpal, which is in keeping with the Bennett's fracture. Our final case then . So this is a patient who had a previous fracture to the right wrist. There's no indication that there's been a new injury. However, there is chronic pain of the right wrist. So if we look at the DP view of the wrist, the one thing that really stands out is how sclerotic the lunate is. And then on the lateral view, we can see that the lunate is still in contact. However, it's very sclerotic. And this is very typical of Kienbock's disease, or avascular necrosis of the lunate. So our PIE form then, it's abnormal, the bone is abnormal, and of course the joint is abnormal because the lunate forms part of the joint. So your overall comment is there's a sclerotic avascular necrosis of the lunate, and this is in keeping with Kienbock's disease. Thank you.